My dear friends, organizers of Avatar, very senior nephrologists, some my gurus, some colleagues and some students, my pleasure to be with you. I have 10 minutes to tell you about history. History is more than 45 years in 10 minutes. I hope I'll do some justice. Just to remind you that it has been a tremendous and huge leap from 1972 to today. So where were you in 1972? It's a short history about the vascular access, but vascular access alone cannot possibly be looked at in isolation. This is a epoch-making picture which brought nephrology to the forefront in India. You see here the Loknayak Jayaprakash Narayan taking a dialysis at Jaslok Hospital with his physician who kept him well and alive for more than almost 2 years, Dr. Mani and his team. And this event really brought nephrology to the scene, to the public view. Until then it was hidden, it was unknown, nobody knew about it. The public sent, the doctors sent the kidney patients to urologists, and it still happens. But this is the one event that changed the scenario. And like this lady whom we all know as the mother of Indian nephrology and to whom we pay our respects today, Professor Vidyacharya, there is in the north still, Professor Chug, who is not here with us, but I believe he has been the recipient of the Avatar Award of Dronacharya Award, and in the south there is Dr. Mani, whose photo I showed you, and in the south also there is Professor Johnny from Vellore. So I ask you to excuse me for forgetting a few or not mentioning a few, but these were the pioneers who got it all started. And we also must pay respect to Professor William Kolf, the father of modern dialysis, a man who recently, I believe, passed away, but has pioneering efforts in bringing nephrology to the Indian scene. And we nephrologists are really nephrologists only different from physicians because of dialysis and transplant. Otherwise, nephrology is pure internal medicine, and the speciality of internal medicine had the sub-branch only when dialysis and transplant came. So it was because of him that we are what we are today as nephrologists. And this was his rotating drum, and this is the flow diagram on which he put cellophane and put blood inside one compartment and dilysate outside it. And this is what it actually looked like, the Kolf rotating drum. This is history, I believe in various places it is still seen as in museums. But it was followed by the Coil dialyser, and those of you who have never seen, I'm sure one or two people must have seen the Coil dialysers, but I used quite a lot, and this was a pre-runner of the modern disposable dialysers, and this is the circuit diagram where the positive pressure was there inside the dialysate, because of which the dialysis, the water and salt removal took place. And this is the old Travenol coil machine in which was immersed, and it was called the Travenol RSP, and then there were various modifications. There was a recirculating single pass dialysis, and this is actually in action. You can see the blood flowing through the coils. And then came these Kiil boards, and we used to build these Kiil boards. I remember Dr. Mani teaching us how to build the Kiil boards, and I was really lucky to be taken in his fold. In Bombay, the dialysis was first started at the KEM by Dr. Vidyacharya, but I was fortunate to see the first dialysis that went on with the Kiil board at Jaslok, and I was so fascinated that I decided that day I will go through the rigors of becoming a nephrologist. And this is a breakdown of the Kiil boards with 4 layers of cuprophane membrane, fixed with this, but I must tell you that there were great many mishaps with this. This is Belding Scribner, who first made the shunt, and these are the shunts that we used to do, and if this were put in either in the leg or in the arm, and you see these vessel tips which were put into the artery and the vein and connected with this connector, and this connector would be disconnected and connected to the dialysis flow through the tubes. These are Teflon connectors, and these were silastic tubes which were used for the shunt, and this is a leg shunt in the posterior tibial and the saphenous, long saphenous vein. And in the arm we use the radial and the nearby cephalic veins. And those of you who are clicking pictures, I believe all these pictures are in the brochure that will be handed out. Is Dr. Umesh Khanna here? He will. Are they all there in that? So these pictures are there. I've put them in. This is part of history. And this was a Buselmeier shunt because disconnecting and connecting caused messes and bleeding. In this shunt, we used to connect over here, right? Just put a needle here and put a needle there, and dialysis would go on. And little heparin was used, standard heparin. These are Cimino and Brescia, who worked at the VA hospital in the Bronx in New York, and I had the privilege also to work there, but this was a little before my time, that in 1964 onwards they worked on this, and they made the fistulas. And so this is the classical sites of the fistulas, and I must say that over the past so many years there has not been really much improvement or increase in the sites of fistulas. However, the techniques have definitely changed, and various new things like exteriorization of the vein, bringing it forward in the upper arm, high fistulas. Fistulas were done in the legs, etc., but they all didn't really survive. The standard forearm fistula and the high fistulas were made. And of course, I must say that although fistula first was something that Dr. Mani taught me in 1977, in 1975, before I went to the US, it was much later that it became popular in the US. And still, in spite of that, when we are going to put up our own poster, it will show you that not more than 25% of our patients, even today, have fistula first. So history repeats itself. Much as we were taught, it was not to be fistula first has not really caught on. And this is Dr. Seldinger, whose technique was used for putting the femoral lines, and the femoral lines became very useful for us. Initially, Shaldon catheters were put, and these were the two single Shaldon catheters. We put them in tandem so that one went ahead and one behind, proximal and distal, and you took off from the distal one and returned it into the femoral vein in the proximal opening, and so there was no recirculation. And I must salute this one person, is Sakharam Mahurkar. This photograph is not in because I couldn't get it. Much unsung hero, an Indian person who made us proud. He made this final diagram of the catheter which he made, and this is something quite unique because there were many forerunners to the Quinton Mahurkar catheter, and we used to use some where the two lumens, one was small and went through the other, but nothing survived except Mahurkar's catheters, and this was the flow diagram that there was, which is still there in the Quinton Mahurkar catheter, and these were the various types of double lumen catheters which finally went into the jugulars and subclavians, and then came the perm cats. And I must end my talk by saying that we've come a long way. The future is great. We've learned to repair fistulas, put lines, and we've also learned, most importantly, to innovate. We've seen that we couldn't get the vascular surgeons to help us, the urologists innovated. So in fact, more urologists in India put these fistulas today than the vascular surgeon, because vascular surgeons are too busy doing cardiac surgery. And this is the use, we had one surgeon, one physician, Dr. Kurvila, who used to put his own shunts, because waiting for people, then people would die from hyperkalemia, waiting for surgeons. So we are very proud of our innovations, we are proud of reuse, which was not allowed abroad, but we started reusing, and then the rest of the world caught on to reuse. And this is my final slide. I'm very proud that this has taken off so nicely in the avatar today, and I'm looking forward to hearing all the new things that are happening in vascular access. Thank you, ladies and gentlemen.